Hello, everyone, and welcome to our webinar covering the topic of the best kept secret of successful therapists, progress monitoring. Thank you for taking the time to join us today. My name is Kristen Frankum, and I am the Director of OutcomeTools. I will help facilitate the webinar today to get your questions answered during the Q&A portion. You will see the Q&A button at the bottom of your screen. Please type your questions there and we will address them throughout the presentation. We also have a poll that is up. If you could take a minute to fill that out, it'll help us know who is in the room while we're presenting. I want to introduce our presenters today. We have Mike Petrie and Ellen Behrens joining us to share their expertise about progress monitoring. They will cover what progress monitoring is, why it's important, and how to implement it within your treatment programs. Mike is a former wilderness therapist and a field guide of 14 years, and he's also the founder of Petrie Consulting, which is a consulting agency and software company that works with providers to measure outcomes and monitor client progress. Ellen Behrens is a licensed psychologist and an associate professor in the Clinical Mental Health Counseling Master's Program at Westminster College in Salt Lake City. Ellen has authored articles on clinical outcomes for youth in residential and transition programs. Her current research focuses on progress monitoring in residential treatment programs. Mike and Ellen have both been involved with overseeing the NatSat Practice Research Network, and we're excited to have them here today to share their experience and knowledge on this topic. So we want to take a quick look at our poll results. I'm going to end the poll for those who have already in here. And if you click on the poll button on your Zoom meeting, you'll be able to also look at those with me. Looks like we have about 19% clinicians and 26% are clinical directors. We have a few executive directors here and a few data collection specialists as well. And a few other professions are joining us. It looks like about 72% of you are doing progress monitoring and 30% are not. And so we hope that those of you who aren't, that this presentation will be helpful for you and will help you to understand what you need to do or what you can do to get that implemented. So we're going to turn the time over to Mike and Ellen to share with you their information that they have today.
Thanks, Kristen. I appreciate it. I'm pleased that we've got some clinical directors on the call, honestly, and I hope that if you're already facilitating progress monitoring, that you walk away from this figuring out how to get a little more out of the systems that you have in place. But if it's not already obvious, our objective here is to persuade you. If you're not doing progress monitoring, we want you to do it. And if you are doing it, we want to do everything we can to support you doing it as best as you can. And so the way that we're going to try to persuade you here, we're going to try to entice you into it by explaining all the known benefits, not all of them, but many of the known benefits to doing it. And we're also going to bring up some of the common obstacles, kind of help you work through how to get around these things. And then we're going to do some role play, some therapy role play, so that you can actually see how it works in real life. Yeah, so let's define what progress monitoring is. So in layman's terms, it's using a measure that actually tracks client change, meaning that it's designed and scientifically vetted to be sensitive to practically meaningful change in a client's life. And you got to use it at regular intervals during the treatment process, and you have to routinely discuss the results with the clients in session. It's really that simple.
And now that Mike's provided an operational definition of progress monitoring, let's deconstruct the title of our presentation a little bit in an effort to explain the benefits of progress monitoring as well as some of the obstacles of progress monitoring. So again, the title is Progress Monitoring, the Best Kept Secret of Successful Therapists. To deconstruct that a bit, let's think about how progress monitoring is or is not used in behavioral health care or mental health care. The research suggests that though progress monitoring is considered an evidence-based practice, and though there are calls for its implementation, even mandates for its implementation from mental health authorities, including the Institute of Medicine, the Kennedy Forum, the Joint Commission, the American Psychological Association. Despite those calls, and despite its qualification as an evidence-based practice, the overwhelming minority of clinicians actually use progress monitoring. A 2018 survey of more than 500 therapists from around the country suggests that 13% of therapists are using progress monitoring regularly in their practice. Contrast this to the healthcare profession. In medicine, progress monitoring is considered a standard of care and evidence-based practice. It's something that we expect when we appear or present for treatment to a healthcare provider. We expect that after we receive a diagnosis of something like hypertension or high cholesterol or diabetes, that our care provider in medicine will prescribe a treatment, typically a medication, and then repeatedly draw labs to track on our response to treatment. That's what we expect because the research suggests that's the best way to deliver effective or meaningful care that ultimately helps resolve the problem. We are finding in the research that the same is true for behavioral health care, for mental health care, that if we are able to routinely measure response to treatment, the outcomes are improved. But the problem is we're not doing it. Now, I know many or most of you are, but the majority of clinicians aren't. And it's important for us to be thinking about why, because perhaps even if you are implementing it right now, you might be experiencing some of the obstacles. And the research has started shifting lately to a focus on those obstacles because in prior years, like in the last 5 years or so, the call has been kind of felt like beating a dead horse or being pecked to death like by a duck, that we keep hearing, do progress monitoring, do progress monitoring. And I think the gap has been that there are obstacles we need to address in order to make it doable for our clinicians and our practitioners. And indeed, that's what we're starting to look at in practice. And that's what this presentation is designed to address. For those of you who are already doing it with some of the perceived obstacles, and for those of you who haven't yet embarked on that journey. Here's a slide that depicts some of the common obstacles clinicians report to us in our practices, as well as have been reported in the recent literature. On the left side of that diving board, you see a number of organizational obstacles or concerns that have been reported in the literature and in practice. The idea is that many people experience that there's so much turnover in their organization, it's difficult to maintain a system, or it's difficult to get a system set up. There is no system set up, and therefore it feels too onerous for single clinicians to manage this. What we're going to suggest in this presentation is that your administration, those clinical directors, those executive directors on the call, have a call to invest in creating a system that is automated and infused throughout the culture of the organization, because then it tends to run itself. Then things like turnover, the infrastructure problems tend to dissolve away because it becomes part of standard practice. On the middle of the pool, right between the toes of the diver, and on the right side are a list of commonly reported concerns from clinicians. You see the one at the top in the middle says, I don't like researcher stats. And to that, Mike and Kristen and I say, great, because this isn't about researcher stats. You'll do just fine. Under that, we hear clinicians often telling us, I don't know how to do this. And to that, we say, well, it's surprisingly pretty easy. Maybe in 1 or 2 trainings that you could do in a team meeting or a staffing or a conference like this, you can pretty easily get what you need to know about your measure to do effective progress monitoring. The biggest complaint or concern or obstacle of clinicians is right between the toes of the diver, right where their eyes are focused when they're getting ready to dive in. And that's that there's too much to do already. And to that, we're going to suggest that when you integrate progress monitoring in your sessions, as we'll share with you today, it should take no extra time, no additional time. And in fact, the research suggests it promotes efficiency in your work and it reduces workload because it can help us with treatment planning, with treatment progress, and even with our staffings and our administration of cases. And again, we'll demonstrate a little bit of that to you later. And then on the right side, you see common concerns also reported by clinicians. Some might suggest it would detract from their clinical work or their way of practice. I'm going to suggest in the next slide, based on the research, that quite the opposite is true. And the last obstacle or concern reported commonly in the literature and in clinical practice is that clinicians are saying, I already know how my clients are doing. This won't help me. And this might be the most alarming piece for those who haven't read a small body of literature, but a very rich body of literature that actually suggests we don't know when our clients are deteriorating. So hold that thought. We're going to come to that in a couple of slides. So what I'd like to do is give you a little bit of information about how progress monitoring can enhance our work and improve our outcomes. And how it can be a secret to success in our clinical work. The bottom line of more than 150 studies, I think we're getting closer to a couple hundred studies in the last 10 years, is that more clients get more, better, faster. Grammar isn't great, but it's actually an accurate way to describe what the research is suggesting. The research, by the way, is good research. As a researcher, I look for things like randomized controlled trials, the gold standard of research, the most rigorous and valid, reliable way of conducting research. And meta-analyses, again, a gold standard way of aggregating lots of good studies, hopefully lots of good studies, together to find what they collectively tell us using some high-level stats. Well, all those studies, of which many are the gold standard, tell us that with progress monitoring, clients experience more change and more clients experience that higher level of change. There's better retention. In fact, dropout rates are cut by up to a half. Think about that. We all know that our dropout rates are pretty high. At some places, they're 40%. They're cut in half. There's less treatment failure. I put that in air quotes because I think it's important that we don't think about deterioration or early discharge from treatment as failure for clients. But nonetheless, it is a sign of deterioration or failure to thrive in treatment. Deterioration rates are cut by 1/3 with progress monitoring. There seems to be faster change when progress monitoring is used. In fact, the treatment length is significantly reduced. And last, it's cost effective. One of the ways that's measured is with readmissions. There are fewer readmissions 6 months after treatment when progress monitoring has been used. Here's another secret of success, one I alluded to in the diving board image. Oftentimes clinicians will say, I don't feel like I really need to do progress monitoring because I already know how my clients are doing. I'm actively engaged, I'm committed to their well-being, they continue to come in therapy and disclose and invest with me. I'm a clinician, I get that. And that's why it was actually discomforting for me, even upsetting or alarming when I read this research. But I've come around to a different position to suggest that maybe this is important for me to hear or for us to hear. Maybe it can open doors to new ways of thinking about our role. Let me tell you a little bit about what the research suggests with our ability to detect deterioration. In essence, the research suggests we're not able to detect treatment failure when it's happening for our clients, nor are we able to predict it as treatment is occurring. So our clinical judgments of deterioration are typically far inferior to what we can have with progress monitoring. Let me be a little bit concrete just to kind of drill that in a little bit. After 3 sessions early in the course of treatment, therapist predictions of clients who would ultimately deteriorate during treatment were accurate only 5% of the time. Whereas predictions based on 2 to 3 episodes of progress monitoring data early in treatment were accurate at least 85% of the time. In another case, 100% of the time. So we got to wrap our head around that. We clinicians, I'm including myself in this as a licensed psychologist for 20 years, is that we aren't really good at predicting which clients are doing well and which clients are likely to deteriorate or fail to get better. There was another study done, which was a post hoc analysis of case notes. And what they did was they found that only 25% of deteriorated clients at the point of discharge were described as such in the case notes. during the course of treatment. Like there was not a record in the treatment suggesting that they were deteriorating, even when the deterioration was dramatic. Again, I know this is like discomforting to hear, but I suggest that it opens doors to changing our approach from that of expert on evaluating our client's experience to one of an ally or a partner who uses benevolent curiosity and a collaborative approach to understand their current experience. I want to say a little bit more about how progress monitoring is a secret of success because it's an evidence-based practice. Indeed, it is considered an evidence-based practice by leading mental health authorities. But this evidence-based practice is different from most other evidence-based practices like DBT or MI or CPT or EMDR. This evidence-based practice is different because it's trans-theoretical, trans-diagnostic, non-prescriptive, and feedback informed. Let me kind of apply that a little bit for you. If you take DBT or MI or CPT, you can appreciate that it is daunting to train in those approaches. It's daunting to be able to have a collection of evidence-based practices that we believe are going to be effective for specific diagnoses and to train ourselves in each of those theoretical approaches that are manualized and created in controlled settings and apply them to our clients, given that they have varying diagnoses, given that we are required to train under various theories to do that, and given that the prescriptive or manualized approach might not seem to fit our style of working with the client or the client's current needs. And in fact, many clinicians feel like, and I can agree with that, that can be daunting or unfeasible to need to know so many evidence-based practices, especially when they're not consistent with your way of practice or seeming to fit the client. In fact, this is why the research consistently shows that evidence-based practices are not implemented with fidelity in clinical practice. This EBP is different. This evidence-based practice is different because it's not wedded to a theory. You as a clinician can use whatever theory you think is appropriate for your client. It's not diagnostic specific. It can work with any diagnosis or presenting problem that your client brings to your practice. It's non-prescriptive, meaning you don't have to go through handouts, worksheets, and a manualized program of care. And it's feedback informed, suggesting that working with clients, we can create a treatment plan, a treatment evaluation, and an understanding of care that is collaborative and interactive and not kind of imposed on the client from a manual or from research.
Thank you, Ellen. I appreciate it. So now we're going to get into the nitty-gritty about how you actually facilitate progress monitoring. So I'm making the assumption that if you're on this webinar, you're probably a Best Notes customer, which means you probably have OutcomeTools, which is it's like survey. If you don't know, it's a survey library and survey delivery system that's embedded in Best Notes. OutcomeTools is a part of Best Notes. So what you've got to do is pick the right tool from your OutcomeTools library. Then you need to review the results so that you know what's expected or what's on the result on your graphs and charts. Then you need to have a discussion with the client, and then you need to use all these data in clinical staffing meetings on a regular basis. And we'll get to that after we break down what a single case and session looks like. So this next slide is an example of the OQ Analyst Clinician Report, which is integrated with OutcomeTools. We're going to be showing you tools that are in two different systems, this tool, and then which is in OutcomeTools, and then we're going to show you some charts that are embedded in the Remote Research Director dashboard, which is our software that is also integrated with OutcomeTools and Best Notes. But what we're looking at here is these are actually live results that have been de-identified so that we can be safe, and we're going to break down each of these three categories and quickly review how to interpret this report. So on this next slide, there's this cell that contains 11 items that belong to the critical item subscale. And you can see that if responses are concerning, then they're in red. So you literally can flash this up on your screen and glance at this and know in a half a second whether or not there's some sort of emergency that you probably ought to be talking about in your session. On this next slide, we're going to see on the left column in the lower left quadrant where it says subscales, there are 6 subscales or 7 subscales to the youth outcome questionnaire. And you can see the second column where it says current, where the red arrow starts, and it says for intrapersonal distress, score of 23. Next column is the outpatient norm, meaning this is what is a normal score for somebody who is in need of or receiving outpatient services. And the far right column is the community norm. This is like the normal population. So you can tell at a glance that the current score of 23 on the intrapersonal distress subscale is in the clinical range. And there's a little bit of a learning curve to figuring out how to interpret these, but after 15 or 20 minutes of looking this through, you'll be able to tell at a glance which subscale is worth speaking of first. And then this final slide of these 3, this is showing you the change trajectory for this individual. So the far left data point with a score of 86 is indicating the baseline score, which probably was taken around the time of admit. You can tell by the dates across the top of the graph that they're trying to collect data about every month. And this is actually a residential program with a 12 to 18 month length of stay. So that's pretty common, about once a month. And we can see that the client's change trajectory is moving in a downward angle towards the right, which is good news, because with the YOQ, a lower score means higher functioning. And that yellow line that sits at 46 on the chart is the clinical cut point, indicating that when scores are below that line, the report is consistent with a normal population, non-clinical population. So we're going to be using these data here to do our role play in just a moment. Let's go on to this next slide and hop into our role play.
Okay, Mike, you are how old are you?
Let's say 17. I'm 17.
Okay. You're a 17-year-old adolescent client. I'm your therapist. So, Mike, I noticed that you completed the YOQ today before our session, and I wanted to go over it with you a bit and talk with you about your reaction to it. First, how is it to complete the measure today?
Well, I mean, I'm tired of doing it. You can see I've done it a bunch of times, but it's fine.
Yeah. Well, thanks for doing it. You have done it 7 times, and I know it feels really repetitive. What I'd like to do today is to show you what your results suggest to us about what's happening now and how things have been going since you came into treatment. Hopefully, in that process, you'll get a sense that it's worth doing this 7 times. Does that sound all right? We go through this a bit?
Yeah, that'd be fine.
Okay. Well, let's start at the bottom. Do you see that graph at the bottom with the yellow line and then the blue line? When you start on the left side of the graph, where you see the blue dot that's indicated by number 86, that's how you were functioning and feeling when you started treatment back in October. And you'll notice the score that you reported even went higher about the second time you took it, about a month in. What that tells us, Mike, I think, is that you were really struggling when you came into the program. And in fact, if you look below that blue line, you see that yellow line that's straight across right about 46. You see that yellow line? Anything above that yellow line suggests that how you were feeling and functioning was so severe or so distressing that it was outside of the norm for most 17-year-olds or most teenagers, that you were really affected and carrying quite a bit of weight, that when most 17-year-olds don't have to carry that much of a burden. Did it feel like that when you came in the first month or so? Yeah,
it was terrible. Like, I didn't have any friends, and the holiday season was coming, and
right.
Super stressed out. Yeah, I hated it.
Yeah, I believe it. And you were really suffering, Mike. That's what I see when I look at that drawing. But then do you see what happened after that? Starting in December, all the way through now to July, your functioning got a lot better. You know, the score goes down, but that means you actually were feeling better. And not only feeling better once or twice, but over the course of 6 or 7 months, you've been feeling better. What do you think of that?
I think it's true. I mean, I've made some friends, and I trust that the staff care, and I'm doing all right.
Okay, I'm glad to hear that. I think that's important. I think what was happening in the first month or so was something you couldn't You couldn't maintain. It was too much to be living that way. I'm glad you've had a significant amount of relief. But you know what else that tells us? Do you see how that blue line in the last 4 or 5 measurements, the last few months, is still above the orange line?
Yeah.
So that tells us that you're feeling a lot better, but there's still a ways you can go. You can have more relief, that there's still distress, that it's still hard for you. What do you think about that?
I believe that. I mean, I'm trying.
Oh, I can tell. And I want to break it down for you and suggest how I too see that you're trying, Mike. If you look up above that chart now, on the right side in that box that has the bold subheading of subscales, that helps us break down where you're feeling the most and the least distress currently, okay? So when you say, I've been trying really hard, and I'm feeling better, but there's still more, we can look at those subscales to see where there's still more you can do to feel better and more I can do to support you in feeling better. So let's do that, okay?
All right.
Okay, the first one is intrapersonal distress. That's just a term that means internally, you're feeling still a lot of emotional distress or a lot of tension. For some people, that's depression or anxiety or strong fears. What do you think of that?
I feel a lot of anxiety.
Anxiety. So you still feel, even though it's better, you still feel a lot of anxiety internally, and it can be overwhelming sometimes. Is that fair to say?
Sometimes I don't even want to get out of bed. It's just the thought of having to walk into a room already full of people. I mean, that stuff just freaks me out.
I can get that, and you've been carrying that burden a long time. Well, in fact, the next scale tells us something important to add to that. See where it says somatic? See that scale entitled somatic?
Yep.
Your numbers there that you reported suggest that the distress you're feeling, the anxiety you're feeling, triggers physical aches and pains, maybe even upset stomachs in a way that really interferes with your daily life. Like it's actually affecting your body. What do you think of that?
It's so true. Like I get so worried that I feel sick and I don't want to eat, and I feel ill.
Yeah, I get that. I can see that. And again, you've been carrying that burden for a long time. But let's look at how that relates or compares to some of the other scales underneath that. The first two that we just talked about, that overwhelming anxiety or distress you feel inside and your physical response to that, those are all things that you know that your internal experience. But the 3 scales after that are the external behaviors that other people see. So your interpersonal relationships, your functioning in school and work and social settings, and in general, your behaviors and actions day to day, all those suggest you look really like you're doing well. I mean, those are strengths for you that in the face of this internal distress that even has hit you physically, you're still getting along well with people. You're still following through on the expectations of your life with school and work and friends. And your behavior has really been adaptive and healthy. What do you think of that?
I think I see what you're saying. I mean, my friends don't really know how worried I feel all the time unless I bring it up in group sometimes.
Yeah.
I think I'm getting along okay with everybody. I just am tired of feeling afraid.
I bet you are. And you know what it suggests is that you carry a lot of that burden alone, that the people who look at you in your life might not even know how much you're affected. And on the one hand, it's a big strength because you can carry all that weight and still do what you need to do and do it well in your life. But on the other hand, it can be quite isolating that people might not understand what you're going through.
Yeah, I think it's probably smart for me to try to open up more about that, but it's just so embarrassing.
You know, I wonder if that's something we can earmark as something to talk about today. What would you think about that?
Yeah, that'd be great.
Okay. I mean, so in essence, is this what we'd be talking about? How you carry a burden inside that you don't show to a lot of other people.
Yeah,
And it keeps you maybe distant or feeling even worse internally.
Yeah, I feel like we're friends, but it's not really intimate because I'm withholding so much of myself.
Yeah, and then that just leaves you feeling more stressed. It's a vicious cycle, I bet.
Yep.
Okay. Well, that's a goal I hope we can come back to. Let's look, before we finish looking at this report, let's look at the words in red on the left side of the top part of the chart. Those are what we call critical items. And all that means is that there's certain things you indicated that would be important for us to talk through, to see what they mean for you and to see if they're things that you'd like to work on. Sometimes the names of those critical items seem way off base. So pay less attention to the titles and more attention to how I explain them to you. Is that sound all right to you?
Yeah.
Okay, so like obsessive thoughts, that sounds like, kind of freaky, but that's not what it's meant. By obsessive thoughts, it means that you reported you tend to have worries that you can't get out of your head. And that happens quite frequently. I think that matches what you told me before, but would you want to add anything to that?
I mean, I've thought about it enough to know that I have so much fear of being embarrassed, can't stop thinking about it. The only times I can really stop thinking about it is like when I'm asleep or when I actually get carried away, like having fun, and then I'm not thinking about it then. But there's all sorts of anticipation to any social interaction that I'm not already in.
Yeah, right. It's completely overwhelming. And it's what is right in front of your eyes whenever you're out with other people.
Mm-hmm.
Yeah.
Yep.
Okay. Hallucinations is another one, Mike. And by that, it suggests that you reported sometimes you see or hear things that other people might not see or hear. What can you tell me about that?
Yeah, I struggled with that question, like those questions, because it's not like I'm feeling little fairies dancing around, but I'm so, like when I walk in a room, I feel like everybody's looking at me, and I don't think they really are, but it feels like it. And then sometimes I feel like people are talking behind my back.
Yeah. So it's not that you're hallucinating in the formal sense where you see and hear things that other people don't see and hear. It's that thing you've talked about before, feeling so embarrassed or so concerned that other people might be looking at you and evaluating you or judging you, that it's hard to get that out of your mind.
Yeah, that's right.
Okay, that's really helpful to know. And it fits with everything you've told me before in our last few minutes. Let's jump down to paranoia. Again, another word that might be misleading. And it's much more important for us to define it in your experience than to pay any attention to that word. It seems like related to that, you were indicating that sometimes it feels like others might be unsafe. They might hurt you. What do you think of that?
Yeah, I mean, I think it's sort of like with the hallucinations, it's like I don't know exactly what to say to those questions, but I definitely feel worried that people are going to hurt my feelings.
Oh, okay.
More than probably is realistic, but that's,
Yeah.
that's what I'm dealing with.
Again, it doesn't sound like the word paranoia at all. It sounds like it fits in with that persistent worry you have about how others are going to treat you or think about you, and that paralyzing anxiety that happens for you.
Mm-hmm. That's right.
Yeah. And the last one, maybe that's important to talk about because you indicated it happens almost always, is what's called delusions here, but I think it's better conceptualized as times that you think you can hear other people's thoughts, or they might be able to hear your own thoughts, even when you don't want that to happen. Now, I can make some guesses about what you meant by that based on what you've already told me, but I'd love to hear it in your own words.
Yeah, I mean, it's like when I walk in and somebody makes eye contact with me, the first thing I think is that, like, they think I look funny or I'm stupid or whatever. And so it feels like I can hear their thoughts.
Yeah. All right. That's so consistent with what you've said before. So when you look at these words of the critical items, it sounds like it's actually, most of those don't apply. You're not having hallucinations. You're not paranoid. You're not having delusions. Instead, you have this persistent or really always present feeling, insecurity or concern and worry about how others are perceiving you. And coupled with that, a significant amount of distress that you hold internally.
Yeah, that's interesting.
So
I wonder what it would be like if I was a little calmer about my.
Well, that's what this leads up to. I mean, this is really useful and important information. I am grateful that you filled out the survey again today, and it seems like you did that with earnest or with sincere thoughts and intentions. And I say, let's turn this into what we work on today. What would be, after all we've talked about, what would be the main thing you want to focus on?
I think I just want to figure out how to quiet my own voices,
Okay.
just how to talk myself out of my worry just long enough to like get involved to do stuff. And I know I've tried before and it's hard, it's work, and I don't know if I can do it, but I think that's probably the most strategic thing I can do.
Well, let's spend the rest of our session building a plan for that. I think that's a great goal, and it sounds important to you.
Yeah.
Okay, so I'm going to pull out of the role play for a minute and highlight a couple things that the research suggests is best for us to do when we do progress monitoring. Research suggests that when we provide feedback like this with clients or engage in a feedback session like this with clients, we focus on not only their current status, which is that last score at episode number 7, but also their progress, that clients do best when they can place now in the context of the entire course of treatment. And we did that with Mike. In addition, the research suggests that progress monitoring is most effective when we not only talk about the distress or those critical items or the high scores, but we also integrate and focus on their strengths, the areas that they're functioning well. And last, the progress monitoring research suggests that the interpretations and the use or the feedback sessions, the use of this data is best when it's done collaboratively. The richest interpretations are those that are collaborative interpretations. For instance, you might have noted if I hadn't talked to Mike, I might have thought that we should reevaluate a psychotic disorder because he's got delusions and hallucinations, as well as some paranoia. But when we talk to him, we see it's actually more a strong pattern of anxiety, generalized anxiety as well as social anxiety that is interfering with his functioning. So that collaborative interpretation is what can be so meaningful, not only in diagnosis, but directing that treatment session as well as the treatment plan.
Great. And I have just a couple comments. Kristen, I'm going to drive for just a second here. I'm going to request remote control. But so the role play that we did was pretty elaborate. It was exempling how you would bring a client into understanding the survey. So there's a lot more time spent than would be typical if this was a routine part of what you do. And there were times when I was a therapist and we were measuring with the OQ45 once a week. And sometimes I'd pull the thing up right at the beginning of the session and glance at it. And there was just literally nothing important to discuss. And that was enough for that session for progress monitoring. So it's not that you go through that whole routine the whole time where, we're trying to show an example, but sometimes it's incredibly brief, or it would just be like, well, it looks like there's no significant change in your report from this time to last. Is that right? Yeah, that's right. And then we move on to whatever the normal agenda would be for us.
Mike, that's a great point. I might add that if you do this as we're suggesting, which is routinely at regular intervals, clients will often come into session. I've seen this with my clients and the cases I supervise. Clients will come into sessions and say, oh, can I see my OQ? And they'll look at it on the screen and say, oh, I know what that means. Oh, can I talk about that one? So it feels like it opens up the session right where the client wants to focus without all that information and training that kind of can clutter it up or take some time.
Yeah, I've even heard about where a client, like a therapist, called me one day because he just started doing this. And he was like, so I just had a client come in and ask to take the OQ45. And I was like, what? He's like, yeah, she had a fight with her roommate. And she wanted to know how it was impacting her mental health.
Exactly. Yeah, great. Thanks, Mike.
So I'm looking up and we're about 40 minutes in. So we're going to go a little long and you can jump off whenever you want. But this next piece is really important for the clinical directors and executive directors in the room. So we've been myopic on the single individual session and how you talk to somebody about their results. But if you pan back and you recognize that when you're routinely collecting these data, then you have some really interesting high altitude perspectives from which to view the health of your organization and to isolate people who actually are in distress and need help, whether because they're getting worse or they're not changing. So the slide that you're looking at here, this is from the Remote Research Director dashboard, and this is actually the clinical staffing report. Its purpose is to make it easy for clinicians, specifically clinical directors, to pull this up in a meeting and just click through the population, the current population, to find the people who are getting worse or not changing. And I know that's so negatively focused. I mean, sure, we want to know about the people that are getting better, but really we need to take action where action is needed. So what we're looking at here, all the clients are down below, and each of these cells is color-coded to indicate the severity of the score each time they took it, the very first time being the baseline score, and the last one being the most recent survey that they completed. So this pie chart here is saying the last time, the most recent completed surveys are broken down into these categories of severity. So we can see we've got this little slice right here that's really pretty severe. It's right up here. So if this were live and I clicked on this slice, then it would just filter the list to only include those individuals. And so if I did that, and we had a couple folks on there, and I just turned to the therapist. First of all, is this accurate? Like, is this an accurate report? If not, what should we do about that? Is it, where are they? And so you just drill in to find out whether or not action needs to be taken. So then you would just work your way back down this pie chart. This one on the right is functioning a little bit differently. So what it's doing is it's saying, if we compare the two most recent completions, what is the change that's happening between these two instances? And so in this case, 13.7% are reporting that the change is clinically significantly worse for everybody in this list. So when I made this slide, I just clicked that pie piece and then it filtered the list. So you can look down here and you can see every one of them went from a less distressed to a more distressed reliable change index. And so then you do the same thing to staff it. You just say, okay, so for this client, therapist of this client, is this a problem? Well, no, actually, in this case, this is great because this person has been in more or less denial and is now starting to do some work. They've opened some doors and that's created some distress. So in this case, it's clinically significant, but it's good news, not bad. Okay, great. What about this next one? You can work through the list. And by using this, you can start to steer your clinical meetings in a direction where you might be focused more on actual reports from clients about how they're feeling than just discussing those that are the most behaviorally disruptive, the squeaky wheels of the program. So it's good. It's a good tool, and it doesn't take long to use it in the session. And then this final slide is this is a clinical director's tool. So let's say you've got a new client and you're trying to figure out which case, whose caseload should they be assigned to. So you can go through and click on your clinicians and you can see the number of folks that they're working with, and you can also get a glimpse of the level of severity of their caseload. So you might have somebody that's only got 4 on their caseload, but it's a really distressed caseload, so it's pretty taxing, and you can make some administrative decisions that way with the clinical staffing report. We've done our best to try to persuade you, try to entice you, explain obstacles, give you an opportunity to see what a session looks like. So we hope that you'll dive in because the water's good. we promise. And then a final message to the executive directors in the house. If you're persuaded by this and you want to implement, take caution and really spend some time staging this, because if it's not staged properly, then it's likely to fail. And if you fail on that first run, it can taint your culture against it, against the whole process. And so to set the stage properly, one of the most important things you can do is hire the right research coordinator. I know we've got a few research coordinators that I work with that are on this webinar right now, and they really are the kingpin of this system, because if your data are not regularly coming through, then the results are less useful. So you need a logistical machine to collect data first. Then you need to help all of the leaders in your organization understand why these surveys are being completed. And you need to systematically install in meeting agendas use of these data so people can close the loop. They will have remembered seeing iPads going around and people completing surveys and having to deal with client resistance because they're sick of surveys. But when those data are then pushed up on the board in front of everybody and used with like real world practical value to make decisions and guide the treatment process, then it clicks and resistance starts to decrease and the whole thing makes sense. And then you've got to plan that after the initial training period, you have ongoing training scheduled, maybe touch-ups once a quarter or whatever makes sense for your organization. But you need to come into it with an intentional plan to keep like massaging the systems and tweaking them so that the data collection and reporting machine run according.
Thank you so much, Ellen and Mike, for providing all this information. We have some questions that have come in, and so we'd like to address those for the next maybe 10 minutes or so. Some of the questions are coming about the graphs that are shown in this presentation. Are they available in Outcome Tools? And so I'll direct that question to Mike.
I'm going to go back through the slide deck. So these charts here about the clinical staffing stuff, this is all from the Remote Research Director dashboard, R2D2. Some of our customers are here. It is integrated with Outcome Tools. So R2D2 gets all of its data and information from OT, but R2D2 for our customers becomes the primary interface with their data. And then if we go back to the progress monitoring, this is the OQ analyst report, which is accessible straight from Outcome Tools. So if you subscribe to the OQ measures and there's a completed survey in your Outcome Tools account on an individual client's profile, there'll be a little icon that looks like a chart, and that just takes you right into this clinician's view of the OQ analyst.
A question about, can you get a copy of this webinar? Everybody who's registered will get a copy of the webinar as well as a copy of the slides. Okay, most of the questions are, how can we find this in Best Notes? So it's integrated with Outcome Tools, and R2D2 are integrated. If you are interested in looking at these charts with Mike, we'll have his contact information available. And that's most of the questions. Somebody said,
there
yeah,
is
go
one
ahead.
question from Judy that says, like, this is all great, but like, I don't know how to use these tools. And it sounds like she's saying, I literally don't know how to go into Outcome Tools and use them. And that's a great point, Judy. I think we probably skipped over that piece. If you want to know how, you can schedule a training with Kristen and she will teach you how to use the tools, and we can do the same. So reach out, book a spot, and we'll get you trained up.
As somebody said, I'm having a problem using the information provided in this presentation because the graphs and presentation of outcome data do not look like this in Outcome Tools. So yes, Outcome Tools provides you the data gathering, and you can export it into an Excel spreadsheet, and that's the information that goes into Mike's system to provide the charting that he has shown us on this presentation.
Somebody asked how they get R2D2, just reach out and let me know that you're interested and I can do a demo.
Yes. Does OT and R2D2 work with young adults?
Yeah, absolutely. It doesn't matter the age of the client.
And then Angela is asking, is there a cost for the R2D2 add-on?
There is, and it depends on the size of the program and how it's organized. So if you're interested in pricing breakdown, just shoot me an email or give me a call and we can chat it through and I can give you a quote.
All right, I think that's all the questions that have come through. Ellen and Mike, do you have any final thoughts you would like to share?
Yeah, one. So as I'm looking at the comments, it seems like a lot of folks came on with an interest to learn more about the mechanics of Best Notes and Outcome Tools, and not necessarily about the value of progress monitoring. So it might be useful for us to host a webinar that's just talking about how those systems work together. If you are interested in that subject, it'd be great if you'd let us know, either in the comments here or shoot one of us an email, because if there's enough interest, we'd absolutely be happy to do that.
Thank you. Ellen, any final words?
No, just I'm encouraged that 70-some% of folks on the call are implementing progress monitoring, and kudos to you. And I hope you let us know how we can support you moving forward. It's important work for our clients.
Yeah, thanks a lot. Thank you, everyone, for coming.
Thank you, Mike and Ellen, for taking the time to do this. This one last slide, if you want to get started on Outcome Tools, if you're not currently using Outcome Tools, you can contact me. And then if you want to talk with Mike, there's his email as well for R2D2 if you want to start looking at your data from the graphing standpoint. Thank you for taking the time to come today, and we are going to have several other webinars over the next few months, and so if you are interested in more topics, please let me know and we can address those topics in future webinars. And thank you very much. Have a wonderful day.